Okay, so as people are trickling in, we will get started. Tonight we have a very, very special webinar. I'm briefly going to start by just thanking the PrecisionOS team by putting this on, introducing our guests. This is our fifth, if we counted correctly, webinar, and this is going to be a very exciting one. We have the most we ever had registered for this, which is really exciting. And we'll be talking about a concept that is so challenging to really understand, which is proximal humerus fractures. And we have world-class guests here. First from the PrecisionOS team, Danny and his team. Thank you always for putting this on. And we're going to have Jay and Ryan, who are going to be in the VR space as well with Dr. McKee. Jay's a fellow at Rothman. He'll be joining us at Duke next year. And Ryan is at MGH. So, and then a special guest is Scott Paxton, who I'll let Danny introduce. But we're going to have a good time. Please put your questions in the chat. And the nice thing about this webinar is also it's an open forum. So if you want to ask Dr. McKee a question, just unmute and we will and just ask him directly. Or you can message me however you all would prefer. But otherwise, Danny, let's get started.
Yeah, thank you, Chris. Thank you, everybody who's attending. This is an extra special VR webinar today because we're going to be showcasing one of our new products with one of the world experts in fracture management of the upper extremity. In fact, many of my colleagues have trained with Dr. McKee over the years, so it's a pleasure to see him. And I want to give special thanks to Catalyst OrthoScience for their sponsorship of today's session. They're doing something pretty innovative in the arthroplasty space with Dr. Paxton is going to give a talk about that. So let me take a moment to introduce Dr. Paxton for those of you who don't know him. Dr. Paxton graduated as a resident from the prestigious Washington University in St. Louis. He trained there as an orthopedic resident and then completed fellowship training in the treatment of both shoulder and elbow problems at the renowned Rothman Institute in Philadelphia. And as we know, there's some world-class leaders in shoulder and elbow surgery at that institution. Currently, he's a member of the Division of Shoulder and Elbow Surgery as an associate professor of orthopedics in the Department of Orthopedics at the Warren Alpert Medical School of Brown University. He's also an attending surgeon at Rhode Island Hospital and the Miriam Hospital in Providence, where he consults as an orthopedic upper extremity surgeon. So with that, Dr. Paxton, it's a pleasure to have you here. And I'll pass it over to you for you to share your screen.
Thank you very much. I appreciate the opportunity to be here and talk about our new implant system. So I'll share my screen here and we'll get going. So thank you for that kind introduction. Proximal humerus fractures are a very, very large area that we struggle a little bit with indications and treatment decisions. I'm not going to go into a lot of that because I only have 5 minutes, but I am going to go into a new implant that we have worked on at Catalyst and my technique for tuberosity repair. So as we know, and we'll hear more, proximal humerus fractures, third most common fragility fracture in patients over 60 years of age. They account for 5 to 6% of all adult fractures. And amongst other treatments, reverse has really become quite popular, potentially leading to fewer complications than ORIF in certain patients and certain fractures, and possibly better outcomes than non-operative treatment in certain fractures. A disclaimer, I do treat a lot of these non-operatively, and I still do fix them. That's what I was doing this afternoon, was fixing a gunshot proximal humerus fracture. But reverse is a really nice arrow to keep if you have the right patient. So we know with reverse for fracture that tuberosity fixation healing is key. We've seen this in multiple studies with better forward flexion, better abduction, better external rotation, better constant scores, better subjective shoulder values. So what are some of the technical factors that we can control to try and improve healing of these tuberosities? Cementless stems, this has been shown to improve healing rates. Neck shaft angle. So studies have shown better healing rates with a 135-degree neck shaft angle compared to 145 and 155 with better forward flexion and external rotation in the 135 group. And we know that fracture-specific stems do better, and that's been shown as well with better range of motion and ASES scores, as well as tuberosity healing. So putting all those things together, I was honored to be a part of a team at Catalyst to design a implant specific for treating proximal humerus fractures with a reverse shoulder arthroplasty. So these are my co-designers, John Brown, Ben Zerlip, and Matt Budge. And I think we've created a pretty innovative and implant that thus far has done well for me in treating these patients. So what did we have in mind when we designed this? Well, we had kind of 4 goals in mind. We wanted secure press-fit diaphyseal fixation with the ability to cement as needed, but the majority of these I think can be put in uncemented. Easily adjust the height of the stem within the metaphysis correctly without having to use excessively long stems or get caught between sizes where you're unable to implant it where you'd like. Limit the complexity of the system, but also provide enough modularity to be easy to use. And then really the main thing was about tuberosity fixation. We knew that tuberosity fixation was key, and there was a bit of a hole in the market for anything that really was specific to tuberosity fixation and healing. The stem, it's a short length 90 millimeter stem. There's a taper connection with the proximal body with the set screw. There's splines, which is a little different than some other implant systems that help with rotational control and really get a nice bite in the shaft. There's HA coating. And then we kind of got clever with the size increments so that they correlated to a change in how the implant would sit by about 1 centimeter. So as you go up one size, it will sit about 1 centimeter higher once you get to a size that starts getting some purchase. And so that can help dial in that height really quite nice. And then the proximal body, really, this is, I think, the most innovative aspect of this implant system with these tuberosity retention rails. And you can see there's one posteriorly, one kind of at the area of the groove, and then one anteriorly, all with holes so that sutures can be passed. And you can use a whole bunch of different suture configurations, and then these specific foci where the tuberosities can sit. They come in 3 size options: 0, 5 millimeters, and 10 millimeters, kind of to help play in with that 1 centimeter difference in seating of the stem, so that you can really fine tune your height. They're plasma spray coated. They're side specific, which I think, to my knowledge, the only implant that's side specific in this space. And then these 2 foci designed specifically for the tuberosities, really focus on tuberosity healing with this implant. This posterior rail is really a great anchor point for the greater tuberosity. And then again, you've got limitless options for your suture configurations for fixation. And then there's a taper fit into the distal stem, also with a set screw, which is quite secure. So this is just kind of a real world example from one of my cases. This is how I set this up. I actually passed the sutures into the implant before I implanted, and these are number 5 sutures, heavy sutures times 3, one all the way at the top, one at this kind of top cerclage position, and then one at the bottom, and then doubled over tapes in the 2 central holes. And what we're going to see here is that when we implant this, we're going to have these sutures here, and we're going to pass the top one through the most posterior aspect of the supraspinatus, kind of the superior infraspinatus, and then the tapes are going to come through the infra, and then the bottom suture more into the teres minor, so more into the kind of the posterior cuff. And then I have this superior suture here, which is passed in mattress fashion. So one end will go out through the anterior supraspinatus, one more posterior in the supraspinatus. So when that's tied down, it'll set my height and bring the top of the tuberosity basically right to the top of the implant. It allows for bone grafting underneath. So once you get your sutures passed, if there is a little bit of an opening, I haven't tied these sutures all the way down, they're just passed, but you can kind of book it open and you've got a bit of a backstop, so then you can pack graft into this area that you take from the head. If you've got a thin tuberosity, you want to get a little bit more lateralization of that tuberosity. And then when it comes to tying, I tie this mattress suture first to set my height, and then I go with the inferior cerclage suture, the more superior cerclage suture, get everything set, and then these 2 central ones I tie as niece knots or a rack and hitch knot to really secure that down. And with the graft underneath, you get a really solid fixation onto the implant, and nice fixation down to the native humerus as well. And then I repair the lesser tuberosity. Now, some people don't repair the lesser tuberosity, but I do that in a similar fashion. And then if you want to repair the interval, you can do that as well. And this is what it kind of looks like at the end. After you have all these sutures, this was a non-union case, so it's a little different than a primary case. But you get very secure fixation here. And you can see as we take this through motion, nice and secure, nice anatomic reduction of the tuberosities. This is the X-ray on the left. It's a bit medialized on the glenoid side because it was a non-union and the cuff was pretty tight, but we were able to get the tuberosity fit nice and snug and secure to allow range of motion to begin passively on postoperative day number 1. Thank you very much.
Thank you, Dr. Paxton. That was a great talk. Just for the audience, one of the things we like to do at these webinars is introduce cutting edge innovations, because I think that there's 2 aspects of surgery that we want to embody here. One is the principles of surgery, and number 2 is the products of the surgery that we all need to execute and provide patients care. Dr. Paxton, I have a question for you. What version do you put the humeral component in when you're doing reverse, and how does that impact your experience with tuberosity healing?
So I like to put it in a native version. I find that allows the most anatomic reduction of the tuberosities for me. In these fractures, generally there is some calcar left to allow you to look at what their native version is. If everything is destroyed, I actually try and build up the calcar again so I can see that area. Usually it's one piece that will have some of the latissimus on it, and it's kind of pulled posterior, inferior. And you can usually reduce that, hold that on there to judge your height. And I also use that to judge my version. I think it works out well with this also because of where the rails are. If you put it in a very different version, you may be changing where you're putting the tuberosities a little bit. And I like to put it in an anatomic position. If I have no landmarks whatsoever, I'll go for a standard 20 to 30 degrees of retroversion. But I generally try and put it in the patient's native version.
That's great.
That was an
Chris,
awesome
you have a question?
presentation. Yeah, awesome presentation, Scott. An awesome implant. I have a question for you. How do you set your height of your implant, especially when maybe the calcar is gone? I think when we work with trainees, that's usually the most common question. Is there any landmarks used on the glenosphere or on the humerus? And then what are some features of this implant that makes it easy to set your height, or how do you use this implant to actually achieve that goal?
So for me, if we see here, there's always 90% of the time there's some calcar remaining attached to the shaft. And so I just try and line it up with the bottom of the calcar. I like to put these in more loose than more tight because I find, at least in my experience and with people that I've talked to in the literature, that instability does not tend to be a problem with these if the tuberosities heal. It's much more stiffness. So again, you can kind of see on this one, I've got a pretty medialized glenosphere, but in a fresh fracture, unless it's some ballistic injury or something, which is what I was dealing with this afternoon, the bone's going to be there. So I'll actually do a little provisional reduction to get the calcar built back up for my height. I've had a little bit of trouble measuring, off the top of the pec. I don't find that to be the most accurate way to do it. If I'm, really stuck and I can't figure it out based on the calcar, what I'll do is I'll take a smaller version of the implant, put that in, reduce it, and then kind of pull on the arm with a moderate amount of shuck and see where the implant and the bone is, and then I'll mark that, and then I'll put that as my height. And that's usually if I'm gonna cement. For a press fit, it's a little different because you're a little it's set a little bit for you where your height's going to be based on the implant. But again, with this, you can trial that. You can go up or down sizes of the stem, and then also the body has 3 different sizes. So it gives you a lot of opportunity to change it within a couple millimeter increments. And then obviously you have the polys that you can change out as well. And so I also look at the reduction of the tuberosity too. So for the most part, you can get some key off of the greater tuberosity. So when you reduce it, you can look and see, is this enough space for my tuberosity on the implant according to the lateral humerus? Or am I way off? Is there no space at all? Or is there a big gap in between? And the other thing is I'm not afraid to use fluoro in the OR. I use a mini fluoro a lot of times just to check. Earlier on in my career, for whatever reason, thought that was a sign of weakness to use fluoro. Now I use it all the time. I'll use it in arthroplasty, whatever. If I don't feel totally comfortable with the way things are going, I just get a fluoro shot real quick.
That's great. Thank you, Dr. Paxton. So the next part is Mike is going to share his screen. And what you're about to see is a video, a live stream video of 4 surgeons in a virtual reality environment. So to put into context, Dr. McKee is in Arizona. We have Dr. Ryan Lohr, who's in Boston. We have Dr. Jay Levin, who's in Philadelphia. And then we have Mike Brock, who's in Ontario. And they're all in the same virtual environment shown here. So I'll pass it over to Mike and company to proceed and talk to us about the proximal humerus fractures and the principles of them.
And again, if anyone in the audience wants to ask questions, please feel free to unmute and just ask them.
Great, thank you, Dr. Goyle, and thank you, Dr. Paxton, for that awesome talk. We're excited to be here.
Quick reminder for Dr. McKee and Dr. Lohr to unmute yourself in Zoom, if you could.
Okay, we're good to go.
Loud and clear.
Perfect. So yeah, we're here all together in the virtual OR, and as you can see, we're here positioned in beach chair position with the C-arm coming in from contralateral, and we can do a lot of things with this setup, but we really wanted to just start off by looking at this fracture pattern. So Dr. McKee, I was just going to pull this out towards us here, and if Mike, you can come and see that. So we have a 3-part fracture that we can displace for us, and we can really infinitely fracture the bone as well as displace these fragments. This fracture planes were sort of preset before the session, but you can really do anything you want in the fracture lab, which is an awesome feature. And Dr. McKee and Dr. Lohr, just curious, I still think the most controversial part of all this is figuring out when to fix, when to replace, and when to just treat these non-operatively. Dr. McKee, I'd love to hear your thoughts on sort of in the modern day, when you feel like we really should be fixing proximal humerus fractures and when we should be letting them heal.
Yeah, it's a great question. I think the general approach would be for most of these fractures is a non-operative approach. So I think the literature would clearly support that the majority of these fractures don't have sufficient displacement or effect on function in that regard to warrant operative intervention. And most can and should be treated non-operatively, especially as you get older and less active. I think if you look at overall numbers, perhaps 15 or 20% need some kind of operative intervention if you want to restore optimal function. And that, of course, depends on your patient. And the younger and more active you are, especially for overhead or repetitive activities, the more likely you are to intervene. I think for most patients, you should be thinking fixation first, and especially in the more simpler fracture patterns with greater displacement, fixation is probably indicated. As you get older, and that's, of course, a shifting target, but there's some increasing literature that now, even from randomized trials, that the older you are and the more complex your fracture is, reverse arthroplasty is probably beneficial compared to fixation. So there's a couple good RCTs from Scandinavia that clearly show the C-type fractures, the multifragmentary fractures, especially if they have bad prognostic criteria for the humeral head, no medial calcar, a lot of displacement, head split, you're probably better off with a reverse. One of the interesting things we found also in older patients, it's always important to ask them what their shoulder was like before they fell and broke it. And as people stay active older, we find a lot of patients who have pre-existing cuff problems or arthritis where they weren't particularly happy with their shoulder before they broke it. If that's the case, that's another factor that would lead you more towards replacement rather than fixation. And of course, the standard now is a reverse arthroplasty for most patients. It's not as dependent upon tuberosity healing as the old hemiarthroplasties used to be. And so in general, it's going to be reverse. For the younger, and by that I mean 55, 60, even 65 patient with a fracture that's not fixable, there's still a role for hemiarthroplasty, especially with tuberosity repair, but you're much more dependent in that situation on the tuberosities healing properly to get good function back. If you are going to do a hemi for a fracture in 2025, probably it's a good idea to use a platform stem. So if you're that unfortunate 1 in 3 or 1 in 4 patients where the tuberosities don't heal or dissolve post-op, you can revise it to a reverse without too much difficulty in getting the stem out. And there's a couple good studies looking at that as well that would clearly show that's very beneficial in that situation. So you could talk for hours about indications, but I think that's generally the approach in 2025.
Dr. McKee, excellent recap of proximal humerus fractures. I just want to make an announcement to you. I will be monitoring the hockey game. And if there's any change in score, I will make sure to let you know.
If I exit suddenly, that's what's happened.
I know what you really care about, so I'll make sure. I have a question for you. When you're approaching these, can you talk about the benefits of a deltopec versus maybe a deltoid split? When do you use each approach for proximal humerus fractures?
I think the workhorse approach is a deltopectoral approach and always has been and still is to this day. And I think the majority of fractures are best due to the deltopectoral approach. There was a lot of interest for a while there, the deltoid split, and became very popular. Though that approach is good if you have fractures that are, significantly comminuted posteriorly. So I don't know if you can see in my hand here, but if you have a big GT piece or particular difficulties in the back posterior aspect of the humeral head, then a deltoid split gets you around the back better. There's no question about that. The group in Montreal did a randomized controlled trial looking at deltopectoral versus deltoid split for these more complex proximal humeral fractures, and they found that the results were significantly better with the deltopectoral approach. So that's kind of tempered most people's enthusiasm for the deltoid split, and I reserve it now for patients who have an isolated GT fracture. If that's the case, then the deltoid split's a good place to be to fix that because you're looking right at it rather than looking at it from the front. But in general, for most 3 and 4 part fractures now, it's a deltopectoral approach. Also, lastly, as someone who does a fair bit of revisions, if your initial fracture fixation fails and you're coming back to revise your failed fixation to an arthroplasty, and someone's done a deltoid split in the initial approach, that's really an awkward case because now you have to dig the plate out from around the axillary nerve, and you have trouble getting around the back to the screws, etc. So those cases are quite complex, and so I'd much rather revise a failed fixation from a deltopectoral approach to a deltoid split. And of course, usually you're revising it to a reverse where your deltoid function is everything. So if you bag the axillary nerve in your revision, you really are in a tough spot. So I think in general, for most fractures now, it's deltopectoral. Isolated GT fractures, I use a deltoid split.
Awesome, thank you.
And we're in the operating room here. Dr. McKee, what is your setup for positioning and C-arm placement? Does this look similar?
Well, usually my patients have some skin and flesh on them, but whatever.
We did the approach for you already. We did it really wide.
So it's almost identical, really. So you could argue whether it's beach chair. I use something a bit simpler, which is like a radiolucent extension of the table with the padded mail stand. Most people use some kind of arm holder with a beach chair type attachment. Make sure the arm comes out the side enough that you can adduct it to get it, a stem down. If this is at most it will adduct, then you have trouble getting a stem down from the top. So make sure that arm can go right into the side. I have the C-arm in from the opposite side. My anesthesia is up top, and that I use for fixation, for nailing, and for arthroplasty. And the nice thing there is I'm very consistent with the setup. And so I work at a teaching institution, so it's always the same for the residents and the staff in the room. And there is some benefit to repetition in the way you do things. And this is what we do pretty well every time. And so that's a good way to do it, I think.
Great.
Scott, do you have a difference in how you set up? Do you do beach chair? Do you do radiolucent tables? What's your setup?
So I do a beach chair. I use a kind of commercially available beach chair, the Tenet, with the spider arm holder. I actually bring the C-arm in from the head of the bed and I flip it upside down. So I'm able to get it kind of right up against the back of the shoulder, but it leaves me a lot of space anterior. So I can actually just have it there while I'm working. And then I kind of angle it so it's like a true AP. So it's out of the way. So, we can work, and I use a deltopec kind of for everything. But I've used other setups like this. I'm not sure how much it matters, but I think doing the same thing every time is really beneficial, especially in a teaching institution.
Yeah, I totally agree. All right, Jay, Ryan, take it away.
Awesome. But yes, I mean, just even in looking at this fracture pattern, Dr. McKee, let's say, sorry, that got real close. So varus
Oh, good
displaced
guy.
with a displaced greater
Hit
tuberosity,
Dr. McKee in
40.
the face. It's not good etiquette for our.
Um, what are you thinking in terms of, attacking this? You're going to fix it. Let's say you opted for plate fixation. What are your initial steps for reduction, provisional fixation, etc.?
So if you look at the literature on the topic, the things that are going to maximize your chance of mechanical success here are make sure that you have a good reduction, and that's obvious to everybody. Make sure there's no varus. Make sure you get some calcar screws in, and then get your tuberosity back where it belongs and fix it there as best you can. And there's a variety of ways to do that, and we'll talk about that. So in general, I would start with fixing the head fragment to the shaft, making sure that it's reduced, and make sure I don't leave it in varus. This is a nice model here, but it's often not quite so simple, and especially in older patients or osteoporotic bone, if there's comminution here. If there's comminution, what I've done is symmetrically shorten. So I'll take the shaft and impact it up into the head fragment. And as long as you do that symmetrically, that's perfectly acceptable. It's a bit unappetizing sometimes on the x-ray because there's a bit of a step there. But if you're trying to reduce this and it's kind of, one cortical point to point here, it's very unstable and shifting around, that doesn't help anybody. So if you take the shaft and impact it symmetrically in the head, so not in varus, but symmetrically, in a pretty stable situation, and then calcar screws, and you want to reduce your tuberosity, hold it with a few K-wires first as well, and then you pick your plate and suture construct to fix the tuberosity. Most of the time we get the head and neck pretty much right. A lot of the time we struggle with the tuberosities, and there's some good papers out there that say one of the major negative impacts on outcome is if your tuberosity doesn't heal in the correct position, it can really have a bad effect, especially on overhead or external rotation. So reduce the head, impact the shaft if necessary, K-wire it altogether, reduce the GT, and then plate position. For this, I'm probably going to cheat my plate a bit superior. There are a bunch of plates out there now from different companies that have flanges to particularly hold the GT, and I think those are very beneficial. There's a couple biomechanical studies that would clearly show that if you have some screw fixation from a flange in a plate into the tuberosity fragment, that's better than simple sutures alone. And we all use sutures and that's fine, but probably some kind of screw fixation here would be nice. This one's going to be good with a standard plate, but if it's more around the back or more superior, it can be quite difficult to do that. So as I said, there's a number of companies out there with newer fixation types to fix that GT fragment back.
Dr. McKee, I have a question for you. There was this big trend about using fibular allograft to put into the canal to prevent the head from falling into varus. What is your opinion on that?
I was just going to ask.
Yeah, that's a great question. It was very popular before. I think that the general trend is away from that. There was one good study from Vermont looking at, it wasn't randomized, but looked at a bunch of patients who had that, who didn't have that for acute fractures, and it found it didn't seem to make a lot of difference. And so I don't use it for fresh fractures very much. I do use it in revision. So if it's a non-union, especially the surgical neck here, I have found it very useful in non-union revision cases, but in general, I don't use it much for fresh fractures. If you are going to use it, and it may be legitimate to do that, just don't, you see some x-rays from 10 years ago where there's like an 8 or 9 centimeter fibular graft down the canal. The problem is if that fails and you come back to an arthroplasty, that is just the most difficult case ever because the allograft always heals in the canal and you're burring away, all the way down trying to get that bone, cortical bone out. It's very, very difficult to do that. So if you are going to use it, don't bury your graft all the way down. 2 or 3 centimeters is all you're going to need. The failure point's up top, not down below. So I don't use it that much for fresh fractures. I do use it in revisions where there's or non-unions where there's a surgical neck non-union. I think it's good for that. And if you are going to use it, don't bury it all the way down to the elbow. Give yourself 2 or 3 centimeters so that if it does, fail to an arthroplasty, you're not trying to burr out all that cortical bone that's healed in the canal.
All right, great answer. So we're going to go into our first poll question. For the audience, how many sutures do you typically use for tuberosity fixation to fix the stem? All right, the poll question should be up on your screen now. All right, Dr. McKee, while this poll question is being answered, I just have a quick question for you, and I'd love to hear what Scott's thoughts are as well. There's been a little bit of movement in the literature and just from talking to people at meetings, and it seems like the patients that we were treating non-operatively previously, over 65 years old, there's almost a trend to do reverses for them acutely for pain control. And some studies have shown that there's better outcomes for these patients that even have non-operatively treated fractures. You have more knowledge than anyone from all the studies you did in Canada and what you're doing today. What are your thoughts on just that movement right now?
I think there's some validity to it. Certainly, it's better for pain control early. One thing that is clear from the literature is that a reverse done acutely in general for fracture is better than a reverse done for failed conservative or failed operative care. So the thing is, you can look at small series from specialized places that have tremendous expertise in shoulder arthroplasty who that would state that a revision of reverse is almost as good as a primary after failed fracture treatment, either conservative or operative. But those are very subspecialized centers. And if you look at, for example, the province of Ontario, where there's a 10 million patient database, all with a unique identifier. If you have a arthroplasty for fracture, your complication reoperation rate is X. If you have an arthroplasty after a failed operative treatment, it's about 5X. And this is a general population, so not a specialized center. So it's clear that if you don't have success with your initial treatment, the reverse that you do down the road is not as good and has a higher complication rate than the one you get initially. And I think that's prompted some people to intervene more. The second thing is we had a lot of trouble with studies trying to show that operative fixation of fractures in older patients was better than non-operative care. There was the famous Profer study and all those other studies that showed fixation with locking plates really wasn't that beneficial compared to non-operative treatment in older patients. And I think most people would agree with that. But we think that the reverse is better than non-operative treatment for certain fracture in older patients that are displaced. And there is some evidence to support that. So now that we have a better tool, maybe we should be more aggressive with intervening. And people say, oh, leave all these fractures alone, or if you fix them, it doesn't make much difference. They're all good. Actually, that's not true. They're all kind of mediocre. And so there's lots of room for improvement if we had a better and more consistent operative technique. And I think some people think that's the reverse in 2025.
Mike, Brock, I'm just going to have you click on the screens on your shared screen because you have some black boxes on there.
Scott, what do you think? I mean, how do you say it more eloquently than that? But good luck.
Yeah, right. That was a great answer. I do think the reverse is very promising for treating these. I think every patient is different, and a conversation with the patient is important. I've had a couple of patients that have come to see me that are 94, 95 years old, and somebody else has told them that they have to have a reverse for their mildly displaced fracture. I'm not sure that's the way to go, to tell somebody they have to have it. I will say that the number of patients that I see, older patients that come to see me because they're unhappy with a malunion after a proximal humerus fracture, is pretty low. So I think they tolerate it. Now, whether they're just tolerating something that's mediocre, I think there's a lot of probably validity to that point. And so I try and counsel them, but I'm a little more optimistic on the acute intervention with the reverse maybe that I was before on some of these kind of tweener fractures. I think there's some that you see that you kind of know they're not going to do, head splits, fracture dislocations. Taking those out of it, I think it's the ones that are a centimeter, 15 millimeters, displaced. They're not crazy displaced that are the ones that are really tough to figure out. And I think getting the patient's input is really helpful too, because some of them really want surgery and some of them really don't. I think their expectations play into their outcome a lot also.
Well, that's a great point. And so the key thing here is you need to know what the natural history of the fracture you're looking at is, and then have a discussion with your patient. This is what's likely to happen to you if we leave it alone. So I had that discussion with a person who had a valgus impacted fracture earlier this week in the clinic. It was pretty displaced. The tuberosity was blown out, and up around the back. But that fracture will heal 95% of the time. The rate of AVN, if you don't intervene, is low. And I told that patient, I said, your fracture will heal. We'll get you moving in a couple of weeks. But you're going to have some difficulty doing overhead stuff. And if you do a lot of rotation away from your body, but you can feed yourself, dress yourself, keyboard, all that kind of stuff. And this person wasn't very active, and they didn't want to have surgery, and they were perfectly happy with that as an outcome. And so I think if you have that discussion with a patient, and then I tell them, and if it doesn't work out, we can come back and we have a replacement now, which is pretty effective, although it's not quite as good as if you had it done initially, as we talked about. If you have that discussion with the patient and of course document it, that's pretty successful patient interaction in my book, and almost always they're okay with it. If they say, hey, I play 8 rounds of golf and 3 sets of tennis every week, and I want that overhead stuff back, then I say, okay, well, we're going to go down a different pathway here, and this is why. So that's critical. Like, all these studies don't say you have to do this or you have to do that. What these studies give you is accurate information to have a good discussion with your patient and make a joint decision. And often, of course, at the end of it, they say, what do you recommend? And you make your recommendation. But that's what these studies say. Nothing ever says you have to do something from a RCT in orthopedics.
Okay, awesome. Jay and Ryan, please
Yeah,
go
that was
ahead.
awesome. And Mike, do you want to advance to the next part? But yeah, so I mean, here we have a good, I think, demonstration of, provisional fixation techniques with K-wire. Dr. McKee, are you using wires for provisional fixation, or are you using mostly the sutures and plate that you're selecting?
No, I try and use a lot of K wires. Obviously, I roughly lay my plate on so I know where it's going to go. And then I try and avoid that with the first K wires. And that can often be percutaneous from the back or wherever if you need to. And then I
Okay.
lay my plate on, and then my plate has K wire holes, the one I typically use to help fix the plate to the bone with K wires. At that point, I'll get an intraoperative X-ray and then kind of go from there, basically.
Awesome. So I
Do
can
you?
place a couple provisional wires
Yeah.
here.
So I'll use my finger, but if you're going to put your plate, just posterior to the bicipital groove, that's going to be a good spot for that anterior wire.
Dr. McKee, do you ever pin the head to the glenoid in a tough fracture to allow some stability?
Yeah,
I
that's
found that
good.
sometimes to
Yeah,
be very helpful.
yeah, I did that last week, so I was having a heck of a time getting a reduction. And when we talk like this, it sounds so easy, but often, as you know, it's very difficult. And the head kept, rotating and shifting. So we basically pinned into varus. So we pinned the head into the glenoid in a neutral position, and then basically reduced the shaft to it. And that was a very effective technique. The only thing I would say is just make sure you use a K-wire big enough, and make sure everyone knows that you've gone across the joint, so no one tries to move the arm while you're doing that, because that could bend or break your wire. So that is a technique that can help you get the head out of varus, and then you basically reduce the shaft to the head, which is in the correct spot, and that's very effective.
Have you played with the external fixator as a tool for maintaining reduction sort of intraoperatively? Like, I've seen people trying coracoid pins it's down to the humeral shaft, kind of lining things up that way. It seems a little bit excessive, but just curious if you've tried anything like that.
You want the short answer?
Yeah,
No.
cool.
We didn't teach you that there at Duke, did we?
Yeah, Klifto taught me that one.
I put
That's wow.
I put a couple screws in the coracoid once, but not on purpose. We'll leave that.
So here we have our wires, and then Mike, do you want to advance to the plate
So,
portion?
Dr. McKee, based on the anatomy here, can you show us and give us some tips and tricks on where you would put the plate?
Yeah, so most plates are designed to go just posterior to the bicipital groove, so that'd be right along here. Sorry, get my finger out straight there, maybe. There we go. Right here, and then down along the shaft, of course. Some of the plates now are designed to go around the front so you can avoid taking down some of the deltoid, especially for those fracture patterns that extend down the shaft a bit. I think those may be beneficial. I don't typically use one of those. I don't mind taking down a bit of deltoid. That also helps you to reflect the deltoid and give you a better view around the back because, typically I'm going deltopectoral from the front. We did a literature search looking for, are there any clinical case reports or series looking at deltoid deficiency or shoulder issues from taking off too much of the deltoid? Because it's a huge insertion. And we actually couldn't find one. So I don't know, maybe someone knows of something out there in literature that we couldn't find. But in general, even though it seems like a good idea to have your plate come around the front down here, I'm not sure it's a clinical problem that we see very often. So I don't mind taking down a bit of deltoid here, and that also helps you get this stuff out of the way. For this fracture, I'd cheat my plate higher. And I have actually used a plate that has a hook type device on top to hold the GT in. I'd much rather have a healed proximal humeral fracture with a GT healed in the right place and a prominent plate that I have to come back and take out and release than having a GT pull off and get stuck up in the subacromial space on the 6-week post-op X-ray. That's a disaster in a young patient. So if the GT pulls off and it gets stuck up and back like it usually does, that in a younger patient, that's a horrible situation to be in my experience. There's pretty good evidence. There's a great paper out from Edinburgh looking at coming back in this situation where everything's healed, just the shoulder stiff. You release the subacromial space, take out the plate, the GT is where it's supposed to be, the head's where it's supposed to be, the cuff where it's supposed to be. That's a great operation and it has great results. Trying to come back and put a GT that's pulled off back where it belongs because you didn't fix it well enough, that's a terrible operation to do. It's very difficult and the results are highly variable in my hands.
So that's my question. Any other release besides the subacromial release? Because we all have patients that are stiff after ORIF. And I always wonder, do you do a release at the same time? Just subacromial space or do any others while you're there?
I take out when I come back in this situation, I take out the plate. I completely release on the subacromial space. You can take down a bit of conjoint. You can take the biceps if it hasn't already been taken. You can release the rotator interval to look in the joint and get a big pair of curved scissors inside and release all the way around. So split the interval, find biceps is right there. Usually, if it hasn't already been taken, I take it in the secondary situation every time. Get a big pair of curved scissors in there, release all the way around it. The coracal humeral ligament you can find and take it off where it goes to the base of the coracoid. So and then, just get your finger all the way around essentially. And usually, if you look at that paper for Edinburgh, that's a very effective operation if you have to come back with the proviso that the main things here, the head and the tuberosity, have healed in the right spot. Then, taking a plate that's a bit prominent out and releasing everything is a very effective procedure.
Reinhardt just scored. Panthers are up 1.
Dang. Okay, thanks for that.
Buzzkill.
Ryan.
How often are you using the flange plates, Dr. McKee? If there's a greater fracture, are you just going to those now just to really prevent that escape?
If it's a GT piece of any significant size, yes, basically yes.
And for isolated GTs, are you using still a similar plate, or do you use a smaller profile plate for, just isolated GT fracture?
Yeah, so for isolated GT fractures, and this is, you're confident there's not a split across the humeral neck. A lot of the GT fractures look off. If you look at it really carefully, there's often an impacted fracture through the neck as well. But for isolated GT fractures, you do a deltoid split. Be very careful of the nerve down here, axillary nerve here. If it's a very thin piece of bone, I may just use suture repair, like some big sutures, drill holes. If it's worth fixing, then I use a small 1/3 tubular plate cut off into a hook, or there's some utility plates now that have a hook on the end for medial mal or something of that nature. I don't use the big bulky proximal plates for that kind of fracture.
Nice.
But the hook around the top is very effective.
Okay, we have an answer to our first poll question. 58% use 4 to 6 sutures. Next poll question: what is the biggest challenge with fracture treatment when utilizing RSA? The poll should pop up now. Ryan J, please go ahead.
Awesome. I mean, the rest is really drilling screws, and I think, doing this under fluoroscopic guidance is probably the best to just confirm your screw length. Are you drilling calcar first, or what's your order of operation? Are you fixing to the shaft and then working on calcar? I know you said you're wiring provisionally to hold the plate.
Most plates now have this kind of oblong hole here. So one screw in the oblong hole in the middle, and then take a picture and figure out where you are. And if you're happy, then you can continue. If you're not, you can, adjust your plate accordingly, depending on where you are. And then once you're happy with that, you can tighten that screw down and you've got your shaft fixed. Then one screw up in the head here. And I use a non-locking screw initially to suck the plate down to the bone, like a 4/0 cancella screw first. So I've got my head fixed, my shaft fixed, and the plate down on bone. And then, but from there, it's usually a calcar screw and then sort of fill and kill after that.
So, Dr. McKee, one of the problems that we find is obviously osteonecrosis and humeral head collapse or screw prominence. When you're putting in the screws, how close to the subchondral bone do you go?
That's a great question. So down low, especially the calcar screws, you can go quite close. So if you look at the pattern of osteonecrosis or collapse, almost always it's the superior screws that penetrate. And the inferior ones are the most important mechanically. So down low, you can go pretty close to joint. And I've rarely seen a calcar screw cause any clinical problems. As you get higher up, then yes, that's an issue. So these ones are definitely not as long or as close to joint as the calcar screws. So go long down below. Up top, it's sort of dealer's choice, but 3 or 4 millimeters away from the joint surface at least would be my usual routine. But I don't mind going quite tight down below, almost to the joint surface, and they rarely cause any problems.
Dr. McKee, and Scott, Scott, you did the beautiful illustrations about tuberosity reduction, but the poll revealed that people struggle most with tuberosity reduction. Any tips from both of you? And maybe we'll start with you, Scott, first on tuberosity reduction, and Dr. McKee, how to achieve this successfully?
Yeah, I think that it can be difficult. I mean, I'm a little bit biased, but I think using an implant that is designed to facilitate tuberosity reduction and fixation is helpful. So, make it easier by using something that's designed for that. But I think multiple sutures, and then I think the Nice knot, or racking hitch type knot, has been really helpful for me. I thought I was getting my sutures tied tight, but
Hello?
yeah, hello. Did you lose me?
Yeah, you cut out the racking hitch Nice knot.
Oh, yeah, and then I would just say, don't be afraid to bring in a fluoro, a mini C-arm. I bring it in, it takes 10 seconds, 15 seconds, just to check it so that I don't get surprised in the PACU. I don't change things all that often, but occasionally I do. And if you're not doing a lot of these or you're not completely comfortable, just take a shot and make sure that you like it.
Awesome answer. What about you, Dr. McKee?
Yeah, I agree completely. So it is without question the hardest part of a reverse for fracture is tuberosity. And I did one today that was like 5 weeks out, and that was absolutely the hardest part of the case. So if you struggle with that part of the case, don't feel bad, because that's what I struggle with as well every time. I mean, anybody can put the stem down the shaft. If you can't do that, you probably shouldn't be doing the operation. And the glenoid's a chip shot because the head's gone and it's a beautiful view, and that's a piece of cake. But the tuberosity management absolutely is the hard part. And if you back up a bit, when we did hemis in the past, the tuberosities were critical. If you didn't get the cuff sewn back together on top and the tuberosities to heal, that was a shoulder that was doomed. And even when you did do it, sometimes it didn't pan out. The nice thing about the reverse is it's not as dependent on the tuberosities as the hemi. If the tuberosities heal where they're supposed to, that's great. It's probably a better shoulder in terms of rotation and strength and stuff. But if it doesn't heal, it's not a disaster. It's still an okay shoulder, and maybe and certainly much better than a hemi that doesn't have tuberosity. So, number one, it's more forgiving in general than what we used to do. The second thing, and I agree with everything Scott said about using a prosthesis and the knot structure, and everyone has a little different way of doing it, but that's dealer's choice. What I found very effective is that if you look at the hemi, you need what's in the front, you need the subscap, and you need what's in the back. You don't need what's up top here. So if you're having trouble getting your tuberosity reduced, or if the rotator cuff looks ratty up top anyways, I just cut it out. So my subscap's in the front, and that's with the lesser, and that's usually okay. The GT, you need the external rotators, but you don't need supraspinatus so much up top. And this might be a bit controversial, but I just cut it out. So I've got a big V up top where there's nothing, because you don't need it in reverse. In fact, maybe it even impinges, and it's better to take it out. But that dramatically improves the mobilization of my greater tuberosity. So I don't have the supraspinatus pulling it up like that. And I did that today. And then you can see very clearly around the back, you can release it. That made a huge difference. And so if I'm having trouble getting tuberosities back down and they're tight, I don't hesitate to take out that superior cuff and just get the front and the back wrapped around. And that's been a very effective strategy for me.
One other thing I would say, and I totally agree with you, is that earlier on in the procedure, how you choose your implants actually, I think, can be helpful. And I tend to go a little more medialized on the glenoid side in these reverse fracture situations. There's a bit of a push and a trend right now to really lateralize on the glenoid a lot. And it can make reducing that tuberosity difficult. And so I go a little more medial. And if I really think that it's too loose, then I'll build up on the humeral side with a bigger poly or something like that. But I go smaller, more medial, and it allows you to reduce that tuberosity a lot easier. And then there's a lot less tension on it, which I think increases the chance for healing.
Yeah, totally agree. Okay, last question, and then Ryan and Jay, while we're doing this, maybe you could keep talking to Dr. McKee and Scott. But are you using a press fit or cemented stem? It's a or B question here.
But yeah, good question.
Awesome. Yes, we've drilled one hole, but so we drill and fill these. We have our oblong, etc. This is it kind of shows our screw tracks under fluoro, which is nice. And really here just kind of popping the cortex and measuring at the far side.
That's amazing. Look at that.
Yeah, I think that's a really great feature.
That is a fantastic feature.
Okay, 68% of people use press fit. All right, Scott, we know what you do. Maybe talk about why you use a press fit. I'd love to hear, Dr. McKee, your thoughts between press fit and cement.
Scott, did you want to go first, or do you want me to go?
Scott, for whatever reason, we're having an issue with your audio.
Now, yeah, sorry about that. Yeah, so generally I use a press fit. Occasionally I will use a cement. If I do that, I go with the black and tan technique. I try and keep the cement away from the tuberosity or the very proximal extent of the shaft. Just I think there might be possibly a chance of some thermal necrosis or just difficulty of the tuberosity healing to cement.
How about you, Dr. P? What are your thoughts?
I used to cement everything back in the day usually because the number of stem sizes we had was limited and you couldn't fine tune it to be tight. But now I would say I almost always use uncemented. We have such a variety of stems now, shapes, every millimeter in size, porous coatings, etc., that I think in general you can get a pretty good fit with an uncemented stem, and in general, that's what I use now.
Dr. McKee, if you have a heavily comminuted GT, are you going in over with the allograft on backup, or in those settings where it's just unreconstructable, not repairable to the prosthesis? Do you like to use anything else to, whether cementoplasty or anything else that you may augment it around your tray?
No, I haven't done that in the past. I've tried to. You can usually get something back there. And again, I don't care about. Let me get my hand going here. I don't care about what's up top here necessarily. I just want this right here. That's all you need for your reverse is the
Hmm.
external rotators at the back. And almost always you can get something, some little shell of bone, and suture them back to your prosthesis. Try and get a few sutures all the way around to the LT, and that gives you like a sling there. So I have not used allograft and I have not used cement in that situation. The nice thing about the reverse is even if that doesn't heal, and I'm not saying we aim for that because we don't, we try and fix it, but it's still a pretty good shoulder, despite not having that, tuberosity heal compared to what we used to see with the Hemis, which was basically a disaster, like a painful pseudo-paralytic shoulder. So
Yeah.
uh, as long as everything else goes well, it's still a pretty good shoulder. And back in the day, I reviewed a few papers that looked at shoulders where the surgeons just let the tuberosities fly and didn't try to repair them, versus shoulders where they tried to repair them, they didn't radiographically heal, or versus the fact that they repaired them and they did heal. And the differences between them were not as dramatic as you might think. Um, and so it's not a disaster where you can't get that tuberosity heal. Yes, we try, and usually they're better if they do in general, but if it doesn't happen, you have to go home and cry on your pillow about it.
All right, Dr. McKee, take us home from the VR space. We have a question from the audience. Can I get your thoughts on utility of vertical sutures for tuberosity fixation in reverse?
Yeah, so if you have sutures in your tuberosity and you get, like, I try and suture the tuberosity to the shaft, to the prosthesis, and if I can also right around to the LT as well. So, and you can, run a running crack house stitch and down through a drill hole in the shaft, in addition to everything that we talked about and Scott talked about. And I think that's useful because it's directly and holds the line of pull of what's left the cuff pulling back. So I think that's a very good idea in certain situations.
Awesome. Well, Jay and Ryan, thank you so much for working with Dr. McKee in the space. Dr. McKee, yeah, what an unbelievable webinar by you. I mean, no introduction needed, obviously, and no closure needed. I mean, professor and chair at University of Arizona and has probably produced the most influential papers that we have in upper extremity trauma. So thank you so much for an awesome webinar. I'm going to pass over to Danny to close it out.
Yeah,
Thanks,
thanks everybody.
thanks
Thank you,
very
Dr.
much.
McKee.
Awesome technology. I love it.
Thank you. So we're going to do a Q&A now with Dr. Paxton for anybody who wants to have specific questions around reverse for proximal humerus fractures. So I'll open up the floor for anybody who wants to stick around. For those of you who would like to leave, that's totally fine. But we're going to open up the floor for Dr. Paxton. Dr. Paxton, while people are sort of settling in and getting their questions ready, what do you find has been the biggest improvement in this arthroplasty system you're using, and how has it helped you in your practice? I think your audio is still not working there. Yeah.
I think the ability to put the stem right where I want it and get a press fit without having to use something that extends really far down the canal has been really a game changer for me. And then things kind of flow from that, whereas tuberosity reduction is a little more anatomic because I'm getting my implant in the right spot. And then obviously the rails, I've played with a bunch of different techniques to try and reduce the tuberosities and tie them in. The one I have now is the one I've found that works the best, but there's a lot of different options, and you can put sutures in a whole bunch of different ways, which I think is one of the main benefits of the stem. But you got to kind of figure out which one you like the best.
Yeah, my next question is, there's a lot of talk about short stems in RTSA. Do you see a role for a short stem arthroplasty in reverse for fracture?
For fracture, it's difficult because even in our stem, the most distal, you get the fixation where the splines are, and you don't get a lot of fixation distally. with it. So could you make it shorter? You could. I'm not sure what the benefit of that is. These patients, we did a bit of research here that when they've had a reverse for fracture, there's a pretty high chance that they could have a periprosthetic fracture later. These are patients that are osteoporotic, they're prone to falling. And for me, at least, doing a arthroplasty with a short stem and then having a fracture after it, it's a lot more difficult to fix than if you have a long.
We lost your audio again there, Dr. Paxton.
He's fixing it. Yeah.
We still can't hear you.
If am I allowed to chime in at this point?
Please. Yep.
I couldn't agree more with Scott. Like we've had a number of these fractures around the short stems. They're very, very difficult to fix compared to conventional stem lengths. There's no real estate up top for screws. If you take the prosthesis out, you have this little shell of bone left up top. It's disastrously difficult. So I'm a big proponent of regular standard stems and reverse for fracture. I agree completely with Scott on that one. And when I first heard about these short stems, I heard lecture after lecture saying it was going to minimize or eliminate periprosthetic fractures. That has absolutely not been the case. I think it's probably higher, if anything, and it's much more difficult to fix technically. I agree completely with Scott on that one.
My question is for Scott. So does your implant have a one length of the press fit, or is it do you have multiple press fit lengths? Let's say you have like a long spiral oblique type fracture that you're trying to bypass on top of proximal humerus, or do you cement in that situation?
So as of right now, we don't. We have longer stems that are cemented, and so in that case, you would, because that's a difficult situation, and you don't really know where you're going to be able to get your press fit. You've got to start including, a lot of different lengths, and this one it just goes to cemented for that.
Okay, any other questions for Dr. Paxton from the group?
Danny, it looks like there's a question in the chat. Panelist thoughts on utility of vertical sutures for tuberosity fixation and reverse?
Yeah, that was actually addressed during the VR session. Thank you, Christine. Okay, well, Dr. Paxton, I want to thank you for your wonderful presentation, and Dr. McKee for all your insights on upper extremity fractures, specifically on proximal humerus. It's a pleasure, and let everybody get back to the hockey game. And for those interested, this simulation is available to any residency program around the world. So if there's information that you would like, please feel free to contact us to get more details, or the ASES. Thank you again. Have a great night, everybody.
Thanks,
Thank you all.
everyone.
Awesome.
Great
Thank you.